the light? A little dark on that last one. Yes, I'm still working my office. Let's see. Got some papers everywhere. All right, guys. So medications part 2 looks like that first video uploaded into our Teams and into Canvas under the discussion board. So, so now I'm going to add on to the last video, going back to 35, 36, and 37. Okay, just what's an allergic reaction? What's anaphylaxis? Need to know those 2 key terms. All right. Adverse effect. What's the difference between an adverse effect and a side effect? And how do they affect the patients differently? We spoke about therapeutic level, if you recall, a while ago, which is the amount of the medication in the blood that is needed to achieve the desired effect. So if you have a medication and it requires this baseline for it to be active, what happens when the medication is above that baseline or below that baseline? So obviously this is going to be subtherapeutic, right? Because we need this to be therapeutic. And if we're up here, we're now going to be toxic. So that means there's too much floating around in the blood, right? And some medications that, some of the common ones that you have to be careful of, or make sure you're checking levels. You got to check your blood levels, labs, before you administer it. Digoxin, gentamicin, vancomycin, warfarin, phenobarbital, and valproic acid. Right, so those are common meds that you will be administering, depending on where you work. But before you administer that, you need to check your lab levels. All right, because if it's toxic, what could happen? All right. So then we were talking about interactions. We were talking about some med-to-med interactions, your herbal interactions, and some drug interactions. All right. So we talked about antibiotics. So tetracycline is another one that it should not be taken with your dairy products. Because remember I told you there was some antibiotics. Well, tetracycline is the common one. Right. So if somebody is taking it, you need to educate them that they shouldn't be taking their antibiotics around with dairy products. So that even includes coffee if they put cream in their coffee. All right. Reading your med orders and their frequencies. What's BID? What's daily? What's as needed? Okay, if it's a one time, what does that mean? Okay, locked bins and narcotics. So what is the purpose of a locked bin in a patient's room? Narcotics will always be kept under 2 locks. If you're wasting it, it takes 2 nurses. If you have to waste it, right? You count your narcotics. If there's a discrepancy, the computer cart or the Pyxis or the Omnicell, whatever your facility uses, will tell you count was 30, should be 31, recount. And then it'll document it. And then you need to call your charge nurse to get it fixed. All right. They go back to the history of where the miscount was, if there was a miscount, so on and so forth, whatever your facility policy. But remember, 2 nurses, witness, right, disposal of a narcotic. So what happens if the narcotic, you're given a morphine tablet and it falls on the floor? Do we just pick it up, give it to our patient? Do we pick it up, throw it in the traps container? Do we pick it up, throw it in the trash? You pick it up and you waste it in the proper waste container designated by your facility, okay, with another nurse. This fell on the floor, and then you got to pull it, and then you got to document that it wasted in the system, why it got wasted. The other nurse will sign off on it, and then you pull another one to give to your patient. All right, let's talk about our PEG tube. All right, so only certain medications can be crushed, correct? Ones that cannot be crushed are in box 36.1. All right, so be familiar with that. All right, and be familiar with box 36.2, which is your forms of liquid medication. We kind of covered Xolair, that it has alcohol and water in it. And people with a history of alcoholism or who are on antabuse or disulfiram, okay, should not be given an Xolair medication because of the alcohol. All right. When you have liquid medications, you need to make sure the bottom line is your meniscus, and that's the level, and it needs to be at eye level when you read it. The solution contains the dissolved substance. The suspension has fine particles, all right? And they are the ones that sit to the bottom. PEG tube, going back to our PEG tube, all right? Remember, if it says it can be crushed, then you can crush it. You're going to mix 1 medication at a time in 20 milliliters of water. You're going to flush that tube, okay? So whether the NG tube or the PEG tube, excuse me, sorry, 30 to 60 mils, right after you check placement. Flush it with 30 to 60 mils. Each med gets mixed alone, okay? 20 mils. And you're going to flush with 20 to 30 mils between each med. And then you're going to clear when you're done with another 30 to 60 mils. If your patient is going to suction, then your suctioning will be on hold for 30 minutes for those that medication to be absorbed. All right. Remember, medications and tube feeds can be, some of them can cause clumping or interaction, so you need to make sure you have a clear line. If they're on tube feeds, you need to hold that tube feed before you give the medication. So remember, your older adults, slower metabolism, if there's chronic illnesses, can affect the metabolism of medications. So it can build up in their system. So if you notice that's your critical thinking. If Sally Joe is not acting right and was fine the other day, make sure you're checking the medications to see what she was on. All right. Those metered-dose inhalers. So you have your inhaler, right? What's the purpose of your metered-dose inhaler? Open up our lungs for asthma, emphysema, some COPD, some type of lung issues, or even pneumonia. All right, and remember, it should be never left in a car because they can explode. They are under pressure. If you have 2 inhalers that are given, you do not want to take them back to back. You need 5 minutes in between. If you have a bronchodilator and then a steroid, you're going to take the dilator first because you want to open up the airway so that steroid can get in. All right, so again, think about this. What do you want the mechanism of action? All right, so the steroids are not going to do its job if those areolae, if the lungs are closed. You want to make sure you wipe the mouthpiece, right, after use, because you don't want to leave any medication around it. Okay. Your dry powder inhalers, Advair is one of them. It's like a little purple round stiff thing. All right. They do not contain, they're not pressurized. All right. So they don't spray out. The patients have to squeeze it and inhale it. Okay. So it's not like the albuterol inhalers. All right. Remember, if you're giving an eye drop or an ear drop, where do you do it? And how much time do you wait? Again, if you have 2 eye drops, so you're going to do them back to back, or do you wait 5 minutes in between? Let's see if I'm so insulin for our subcutaneous, the 24-hour acting that cannot be mixed with another insulin is your Lantus or Gorgoglin, and that should be given the same time every day. Filter needles are used for your ampules. Remember, you're going to break away from you. Right, you're going to clean the neck of it, break it away. Use your filtered needle to draw up the correct amount. And you get dispose of that filtered needle because it's not one you're going to use. Switch over to the proper needle, syringe, whichever you're going to be using for the administration of it, the medication. Reconstituting. Important thing to remember about reconstituting is you need to follow the directions. If it tells you to reconstitute with 10 milliliters of normal saline, that's what you reconstitute with. If it says to reconstitute with 50, that is important. You need to reconstitute with your medications and whatever it says. Okay. For insulin, if we were mixing NPH, so regular and NPH, remember we have 3 sticks. So how many insulin? If you have your 2 bottles, if this was my NPH. Okay, so NPH, regular. All right, you're going to inject air into this one first, whatever the air is required. Then you're going to inject it into the regular second. Okay, remember, don't contaminate it. You're going to flip it upside down, draw out your required amounts, set it down, and then you would stick your needle in and draw out 3 needles. Remember, every time you stick your insulin needle into a vial, it dulls the needle and it will hurt a patient. Bevel up, as I said in the previous video, and 45-degree angle for our subcutaneous. What's hypoglycemia and hyperglycemia? So hypoglycemia is when hypo is low blood sugar, cold and clammy need some candy. All right, and what are the signs of hyperglycemia? They're hot, they're flushed, they're thirsty, they're fatigued, they're sleepy. They have this fruity breath odor. All right, you need to take action appropriately based on your patient's status and hospital policy. All right, so remember the lipoatrophy and the lipohypertrophy. Those words are very hard for me to say. Okay, from repeated insulin injections in the same spot, they develop little fatty tissues. And at that point, the insulin is no longer going into the subcutaneous because it's like hard and rock. Just think of a ball. Okay, if you have a knot in your skin, that would be one. All right. All right, so remember, if we were teaching insulin to our patient, what is the best way to evaluate that they understand how to do a blood sugar demonstration, right? Demonstration will always. I'm going back a little bit. Member Z-Track, and the purpose of that Z-Track is to keep the medication in the muscle so it doesn't fall out into the subcutaneous. 90-degree. Remember, the size of the needle is dependent on your patient. The bore of the gauge is going to be dependent on the type of the location and what medication you're given. Know your injection sites for your IM shots, your sub-Q shots, and your intradermal shots, and your landmarks. All right, I think this was a little longer. Yes, let's see how it uploads.